I am, as they said, Dr. Maren Wright Voss, and I'm a health and wellness faculty member with USU Extension. And this Blue Plate Research special is about opioids. And there is just a lot to talk about with opioids. So if I were a neuroscientist, I could talk about the long-term opioid use, how it transforms the nervous system, how it fundamentally changes how people perceive pain. And if I were a human development researcher, on the other hand, I might talk about how opioid misuse damages family relationships, how the emotional development children could be harmed when a parent overuses opioids. And then if I were a historian, maybe I would talk about the first evidence of people collecting opium pods 5,000 years ago. A historian might explore how Indo-European trade routes and the opium wars in the 1800s led to opium dens in the early 1900s. And then more recently, there's been the development of synthetic opioids and how those events have led us to the opiate crisis of the 21st century. But I'm here to focus my remarks on opioids from the perspective of a health science researcher. So others study DNA and genetics, but I look at culture and policy and economics to understand disorders that can be co-created by societal and individual mechanisms. Now, I am very practical. In Extension, we're all about programs that make a difference. So I seek to understand interventions that work to combat negative societal factors, and then how can we empower people to help themselves? So that's what we're all about. Today, I'm going to discuss two of my main programs. So there's pain management education and peer support specialists that I want to talk about. This is all part of a harm reduction approach. And I'm also going to talk about how we've adapted our efforts to serve rural Utah. I'm going to talk a little bit more about the HEART team, the HEART initiative, and my role on it. And then just a little bit of a perspective on grant writing. I have a unique perspective, you might even call it a personality flaw in that regard that I'll talk about. But before I get to any of that, I want to go over just a bit of history. Let's spend a little bit of time talking about the factors that lead people to opioid misuse and how this illness affects people's quality of life and really why it's a societal problem. So this isn't our first opioid crisis. Before the current crisis, we saw an opioid crisis in the early 20th century. So at that time, opium was smoked in opium dens. Inside homes and hospitals, it was used as like this miracle drug to treat all kinds of problems. And when we look at the historical literature, we see the same kind of addiction issues we're seeing today. Back then, policymakers started to recognize the harms, and that's when opioids became a classified drug that you could only get through prescription. And so eventually, with that change, the opiate crisis petered out enough that it was really kind of only impacting the fringe of society. But then in the 1990s, we heard this new outcry from the public. So people wanted better pain management, and patient advocacy groups started talking about this right to pain relief. There was a 1995 address to the Pain Management Society that urged the adoption of pain as the fifth vital sign. And that really caught on. They were saying that doctors needed to monitor a patient's pain and make patients more comfortable. At that same time, and just a little bit before that, in 1980, there was this 5-sentence commentary that appeared in the New England Journal of Medicine, which suggested that prescription opioids really didn't have a high potential for addiction. Astonishingly, that sort of false notion, it was based on evidence, but it wasn't really, the whole story. It got perpetuated over 600 times in the ensuing years, justifying more opioid treatments for pain. So then at that point, pharmaceutical companies responded. They manufactured drugs to keep patients comfortable based on this perceived need, and then they marketed those drugs, justifying them as safe. That's how this current opioid crisis emerged. That chain of events led to a prescription, an increase in prescription by doctors. Perhaps they were a little too easy on prescribing. You then saw that increase leading to an increase in opioid overdose deaths, which you see here to some extent in this first wave. You see it a little bit more here through the second wave, but then I want you to pay attention to this second orange line, because as we started to become aware of this problem with prescription opioids and the addiction issues, doctors started leveling off their prescriptions, much like we just heard about. And then that led to an increase in heroin use as patients who were dependent couldn't get the medication from doctors. And then more recently, an alarming spike of synthetic opioids with fentanyl on the streets that's led to even more overdose deaths. So back in 2005, Utah had the highest opioid overdose rate in the nation. And since then, you saw how we leveled off. And that to some extent is because our prevention efforts were working, which is a really good thing. But just as was mentioned a minute ago, the COVID impact has really created some additional burdens, and we're seeing those opioid overdose rates spike back up. Here, the American Medical Association in their issue brief offered just this month, they're citing this problem. And so we need to talk again about making sure that we're doing everything we can to address this around our state. So the US Department of Health and Human Services designated the opioid crisis a public health emergency back in 2017. And then in 2018, this HEART team, this HEART initiative was formed, created by USU Extension, and really by a very forward-thinking dean who realized that Extension is ideally situated to bring evidence-based practices into our communities through the land-grant university mission. It just pairs up really well with the partnerships we already have out in the communities. So that's how HEART was started. As Dr. Crockett mentioned, it stands for Health Extension, Advocacy, Research, and Teaching. You know, everybody needs a catchy acronym, right? So that's ours. HEART is the expanded arm of Extension that's focused on health and wellness. And so 5 new faculty members were hired. They were given this mission to address Utah's opioid epidemic, and opioid harm reduction was our focus from the beginning. I serve Salt Lake County and Tooele County, but many of our efforts are statewide. And while HEART started with 5 faculty, USU Extension faculty from other areas of the state already working on health promotion joined the initiative. So here's a quick video of my colleague, Susie Prevedel. She's talking about her work in Roosevelt and Uinta counties here in Utah, and I want to share that with you.
Making relationships is key to what we do in small towns. It's really nice to be able to reach out to people and help each other get their jobs done. If I can help somebody else in their agency get their work done better, I know they will do the same for me. Hi, I'm Susie Prevedel. I work for USU Extension. I'm the director of the Tribal and Rural Opioid Initiative Resource Center, also known as TROY. I've lived here for about 30 years, and I live just on the Uinta County line. The school that my children attended at that time was Todd Elementary, and it's about 85% Native American students. So from the very first time I started making connections in the community, they were with Indigenous community members, and I've enjoyed working and being part of that community. One of the things we can do working through Extension and using the research that's available to us is if we come in and we're humble and we do a good job listening and we're respectful and figure out really what's not what we need, but what our communities need, then we have a much better chance of helping them get another step up. The science doesn't change, the statistics are there, the best practices are there, the things are there. The way that we deliver needs to change with that, so we really worked with the presentation to leave open space for people to bring in their own specific resource information. We also changed it to reflect the community that the presentations will be giving to. We also spend time with a training manual so that a community member from the community can look at it, work with our experts, and then deliver the trainings to their own community. It's not something that we hold proprietary. In giving our naloxone presentations at the tribal community, who were hosted by Michelle Chapus, we noticed that through multiple trainings, people became more comfortable. They were really willing to give feedback, so it came more of an exchange of ideas on how to make things work better. So we felt that was pretty successful, and we'll continue working that way with our tribal communities.
I hope you heard from her that importance of listening and those community connections. So it really is about tailoring our approaches to the community. Like Susie, the HEART team, we consider the community members the experts, and we listen to the community and adapt our programs to their needs. One of the first things I heard when I did a listening tour was that our communities needed more pain management options. So they could use something other than opioids, something with less risk to overcome their pain. So that's where I started as a new faculty member, was with pain management. So first off, as we talk about pain management, there is something you need to know. Americans are a little bit unique in our attitude toward pain. Specifically, we don't want to feel any of it. We want it all gone. We use more opioids than per person than any other developed country out there. The second thing that you might be helpful for you to know is that pain is a complicated process. So giving people more opioids doesn't necessarily result in lower pain levels. There's these intricate reaction patterns called the neuromodulation of pain that can result in sort of an oversensitivity of the nervous system, where you're feeling more pain than you should based on your condition. All of this is pretty complicated. And one of the things we do in Extension is we create community-facing fact sheets with really easy to understand information using the evidence base and presenting it in a way that community members are able to access it. And so using images like the one you see here, we create a number of community fact sheets trying to get good information out there about how people can find better options for things like managing pain. Another aspect of our success is our partnerships. We've been able to develop some amazing partnerships in Utah. We connected with people at Intermountain Health, with the University of Utah, with Utah's Department of Health's Living Well programs. And we were able to offer these Stanford-based, evidence-based education programs called Living Well with Chronic Pain. This is an amazing workshop series. It takes about 6 weeks. It has about 15 hours of education on pain management using this entire toolkit of approaches, walking people through some of these different approaches and how to use them. And the classes have information on things like regulating sleep, how to make action plans that help you manage your pain, how to pace activity so that you're in less pain even though you're staying active, some gentle movements that can ease muscle tension, just a whole bunch of things, a bunch of cognitive strategies on how to think differently and to use your mind to distract and to experience less of the pain, even if your body's still experiencing it. And we've had just some amazing feedback from people who take these classes. The comments we get are that the classes are transformative and that people are able to stay more active and even be able to use less pain medication after taking these classes. So they've been really effective. But while these programs are awesome, they require a ton of training. And it's been hard to get them into rural Utah, where our numbers are small and we have fewer people to facilitate and to take those trainings to offer the classes. So I'm going to touch on a little bit more about our rural outreach in a minute. But again, Extension is all about making our programs accessible. So we took this same evidence-based toolkit approach and we created a program that we call PEACE, again, another catchy acronym, but this one is Pain Education and Community Empathy course. And we created a manual with 12 really easy modules. They're like 12 scripts where people can, walks people through one pain management strategy in a script format. So you can have one facilitator who basically reads through the script, gives people the evidence-based information as they gather. Then they can try out some of the techniques. So they try out things like some simple exercises to get muscles moving again, some ways to reduce tension, some ways to visualize and use your mind to distract from the pains. They practice breathing techniques in some of these scripts. And so people have this little encounter with some pain management strategies, but then they're there together as a support group. And really having a community to support you, to learn about their resources and what they're doing to manage pain has been really, really helpful. These classes have been working so well. We've even started a partnership in Tooele where we've been able to bring these PEACE support groups into the jails, because some of the people we serve come from really vulnerable populations like our prison population. So let's shift gears just for a quick minute because I want to talk about serving these vulnerable populations. So this is a type of harm reduction. This graph right here shows that recently incarcerated people generally have a higher risk of overdose death. So within that first year of incarceration, it's about 10 times the average. But that middle column, that shows the 2 weeks after incarceration. And your risk of overdose is 40 times the national rate. That's scary. And what that means is I want people packing naloxone as they leave incarceration. Naloxone is this amazingly safe medication. If you haven't heard about it, why it works so well is it can bump the opioid off the receptor. And so what happens is a person can go from having so much in their opioid in their system that they can't breathe to breathing easy again after a naloxone dose just within moments. Now, unfortunately, the most affordable form of naloxone comes in a vial accompanied by a syringe. The good news is it's only about $20 a dose, but as it turns out, our police partners don't really love us handing hypodermic needles to people as they walk out of prison. So, unfortunately, the police-approved version, the nasal spray version of naloxone, is about $100 a dose, and nobody has a budget for that. But with the community engaged work we do, I was able to partner with a nonprofit called Harbor Path, and we received 1,200 of these Evzio naloxone kits. These are an injector style. It's a little bit like an EpiPen. Now, these injectors normally cost about $500 a kit, but they sent it to us for just the cost of shipping. So for us, it was $2 a kit. These are safe. And now in partnership with the Twilla County Jail, people are handed this safe naloxone option as they leave incarceration. And that is the kind of community engaged work that will really have an impact on saving lives in our community. But I call this next little section of what I'm going to talk to you about grant writing to the rescue, because that partnership I mentioned with the Evzio kits was brought to you through the power of a grant. A $2 kit doesn't cost much in terms of grant dollars, but I needed the grant relationships more than the grant money in order to get that relationship to happen. I couldn't have done it without my federal funding partners helping me make those connections. Now, if you spend any time around a university, there's a good chance you've heard people complain about grant writing. I'm not one of those researchers. This could be my motto. I love writing grants. I seriously love writing grants. It's really a sickness, most likely. I see grant writing as this fun collaborative process where you see a need and you get to creatively think about what's going to fix that need. As I do this, I get to partner with amazing people. Now, the number one partner you're looking for are the people who want to give you the money. And that might be kind of obvious. But you have to ask a few questions. What's their vision? What are their goals? What are they willing to give? And why are they willing to give? So after I find a funder who has a shared vision, then I have to come to them with a really well-developed project and a plan. And I can't do that on my own either. So nothing happens, as you know, in community engaged work with just one person. So this step requires a lot of partnering. I get to work with assembling this team of other community members and professionals, and we get to talk about how we're going to fix this problem. So we kind of like raise this cloud of ideas, things like our hopes and our goals and barriers and budgets, and we kind of let them rain down until we organize this proposal. And what we're doing is we're telling the story of our community need and why we're the best ones to address it, to get things to be resolved. So in that process, there's a lot of emails, there's a lot of paperwork. It typically takes about 2 months. We're turning our dreams into this written proposal that makes sense on paper, that's going to convince the funder to give us money. And then after the grant is submitted, you just wait. So far, with the support of USU Extension's administration, as well as some really awesome people at the Office of Sponsored Projects, we've been successful on every one of our federal funded opioid applications. And because of that funding, I have 2 harm reduction programs running in Twilla County. And then I also have a statewide $2.5 million grant that is really starting to show some big impacts that is pretty neat. It's focused on building the treatment workforce with a really cool new type of professional called a peer support specialist. So we're listening to our community and doing what makes sense for our communities. And when we did that initial listening tour, we listen to people in recovery. And one of my good friends at Young People in Recovery told me how much it meant to him to give back to others who are struggling with substance use, and to do something to change those negative societal factors that really make it so hard to advance through recovery. He started a chapter of Young People in Recovery to be that difference, because he believed in the power of having a friend. And really, this idea of peer support is one of the most exciting things in the past decade in substance use treatment. You've probably heard of AA. They've had sponsors for forever. But finally, someone started to realize that that idea of a sponsor worked so well, people should get paid to do it. People in peer support, they don't need a college degree because they have a degree in life experience. One of our friends at USARA, which is one of Utah's biggest peer support networks, Mercedes, told me, "My mess is now my message." So in saying that, she's saying she's using her recovery story as a story of hope and healing to encourage others on the journey. And it's really powerful what happens when you have someone with experience helping you through the way. She's a trained and certified peer, and we need more of those. Why? Because when peers are on the treatment team, people stay longer in treatment. We call that treatment retention, and that means better outcomes. People report more hope, more empowerment, better quality of life, but it also helps the bottom line. We see lower rates of hospitalization and lower rates of future arrest. So societally, it's making a difference as well when we have more peers on our treatment workforce. So you might, if you're new to this idea, wonder what peers do and why we're so motivated to train more peers in the state to help this problem. They can lead groups, they can provide one-on-one support, they do crisis response, they do this integrated health, connecting people to all the types of health support they need. They connect people to resources. So that could be things like housing, job training, help them with interview skills. And they do some general patient advocacy as well as 101 other things. But as an added benefit, being a certified peer support specialist provides meaningful work for the person themselves while they're also in recovery. Recovery isn't just like this 2-month and it's over kind of process. It's an ongoing process. And so to work in that recovery space helps the individual who's in recovery being the peer along with the people they're serving. So it's really a win-win in a war on drugs that really needs a victory right now. Now, I want you to know that Utah has been at the front line in training and promoting reimbursement for certified peers. So here in Utah, they can bill Medicaid if they provide supervised services. And we need peers on our treatment teams because Utah has a workforce shortage in behavioral health. Looking at this graph, everything in gray is a workforce shortage. We do not have enough behavioral health workers across the state. Then the dark gray is where there's a higher need, geographic needs, and the red is where it's higher need because of low income, where both of those areas need additional services. So getting more trained peers out into the field can help pick up the slack because doctors and counselors can't do it all. I've been talking with some of our partners recently, and it's so hard for them to get trained professionals out into their communities, and peers can help fill some of that treatment workforce shortage space. So we want these certification problems available across the state, but particularly in rural Utah, because rural Utah has been hit a little bit harder by the opioid epidemic. I think you maybe have seen how the Price and Carbon County areas have been extra hard hit. And there's several reasons for this. They have less access to treatment. They have fewer alternative pain management options like massage therapists, physical therapists, some of the other professionals you might need for alternative pain management. They have fewer specialists in their area, and they have people working in more physically demanding jobs. So that means more likely to get injured. And you also see people a little bit more likely to keep working even while they're in pain. So that means needing a little bit more pain relief out in rural America. I want you to check out this graph with Tooele County. That's one of the areas I serve, and it has one of the highest opioid overdose death rates in the state. But check out this next graph. Here's that same data again. Tooele's on the very bottom of the graph here, and you see the high overdose rate next to the treatment resource availability, and you can see how limited the resources are in Tooele, and you'll see that in several of the other rural counties as well. And so we really need to support the workforce out in our rural areas in order to be able to get people the resources they need. So my grant goal is to build those treatment resources. So to become a CPSS, a certified peer support specialist, takes about 5 days with 8-hour sessions. That's about 40 hours of training to become a certified peer, and they pass an exam in order to do that. It's really hard to expect someone who's living on a minimum wage job out and maybe in Panguitch to travel up to Salt Lake City, take 5 days off from work, pay for the hotel, pay for all the other travel expenses in order to get this training to once again go and work in a behavioral health job that also has a lower pay scale than some of the other types of work out there. So one of my grants wanted to make CPSS training more accessible. So we set up this hybrid format where individuals interested in this recovery support training could do half of the work online, and then they could come to just a 2-day in-person training in order to certify themselves with those additional skills that they need to be a peer support specialist. We managed to get a grant that's going to pay for 365 peers to get this training in Utah over a 4-year period. It also gives some stipends to support them because the salary wages are fairly low for people who are certified peers. That will give them some stipends as they do internships and apprenticeships and as they develop their skill set in this area. And we've trained 52 peers in the first year. That again is the type of community engaged work that's saving lives and that can make a difference. So here in USU Extension, we are adapting how we deliver information and services, and it's making a difference, but we can't do it alone. So what can you do to help? Well, if you're thinking that a person with opioid use disorder are just addicts who just need to figure out how to quit, stop. Change your thinking. It isn't helpful to think about the disorder that way. These are people in real pain. They were given meds to help. Perhaps a doctor's prescription made them feel a bit too safe in taking the medication. Maybe long-term use changed their nervous system and it may take years to recover. But there are prescribed medication treatments that can help people if we assure them it's okay to take medicine for addiction. We like to think of it, because addiction is a long-term chronic condition, we like to think of it like diabetes, where we're giving people the equivalent of insulin to help them through that crisis. So we need to change the way people are thinking about access to support and resources to get them through recovery in order to make this difference. So what that means is if you're an elected official, you could maybe hold a town hall. You could encourage harm reduction trainings that give this extra information to county or state employees or to others in your area. And you can support the building of prevention coalitions in your area as well. If you're justice, education, healthcare, workforce individuals, you are one of the people that can connect people to the needed resources. Again, that stigma reduction, being aware of all the types of harm reduction options available is important. And you can conduct those types of trainings at your agency to make sure all of your staff is aware and has that perspective as they help people with the opioid problem. If you're a business owner, maybe you want to sponsor some recovery organizations, some recovery events, or just make sure your environment at work supports mental health. And then if you're a community member, we can each reduce stigma by changing our language, not using the language of the addict, using person-first language, those other kinds of things that will support people who are struggling. You can show support for any recovery path, whether it has abstinence or not, realizing the chronicness of the condition of substance use disorders. You can attend prevention coalitions where there's going to be tons of ideas on how to take action there. But generally, I also just encourage you to know the options and the resources so that if you have a friend or a family member in need, you're going to know how to connect them to support, get them the help that they need. So if you want any of these harm reduction education opportunities in your community, we can help through USU Extension. I've been talking about our program implementation, but we do research alongside to make sure that these programs are effective and having the desired impacts. We have naloxone trainings, we have those pain education trainings, stigma reduction trainings, and all of these resources, community classrooms, pain education, in order to help in our communities, because prevention is important. We know that there's a measurable benefit from the pain management techniques we've been sharing that can help people manage pain with less risk of opioid overuse. And we know that peer support is this amazing new approach to treatment. And if we can get more peers in our communities, that's also going to make a difference. So remember, we can adapt our messages and services, and let's meet people where they are and make a lasting difference. And thank you for your time and your interest in this topic. It's so important.